A 37-year-old man comes to his physician for a 3-month history of progressive confusion, lethargy, difficulty walking, and episodes of myoclonus. He was previously healthy, but says he now has difficulty remembering familiar people and often gets lost. He reports that his mother and maternal grandfather had similar symptoms before passing away. An EEG shows spike wave patterns. Which of the following is most likely responsible for this patient's symptoms? Choice A, mutation in gene related to presenilin-1. Choice B, blockage of arachnoid granulations. Choice C, increased formation of PRP-SC. Choice D, aggregation of tau proteins. Choice E, buildup of Lewy bodies in the brain. Choice F, decreased function of ceruloplasmin. I'll wait 5 seconds and answer the question. So this is one of those conditions where you have to remember a number of just buzzy terms they like throwing at you. When you see somebody with these kind of diffuse neurological signs, especially with myoclonus, and what appears to be a very rapid onset, here you have 3-month history, you should be immediately suspicious of Creutzfeldt-Jakob disease, CJD. So the correct answer choice here is choice C, increased formation of PRP-SC, which is the pathology of how CJD occurs. You have a normal PRPC, and then it gets converted to the pathogenic PRP-SC, which can go on to convert even more PRPC into PRP-SC. It just goes on until you form several prion aggregates and will cause a gross spongiform change. That's why it's called spongiform encephalopathy. I would remember the whole vacuoles or spongiform histology more as something they might give you as an answer choice. I don't think I've ever seen it given in a question vignette itself, because that makes the question way too easy. And in real life, you wouldn't get it anyway, because usually Creutzfeldt-Jakob, you can only confirm it via histology/biopsy after the patient is dead. So CJD is mostly sporadic. Something like 70 to 80% of CJD is sporadic. So that can present usually more in elderly patients, but here you have a younger patient, which is more suggestive of an inherited CJD, which of course we also say that there is a mother and maternal grandfather with similar symptoms. For inherited CJD, it is typically inherited in an autosomal dominance pattern. So if they're trying to push you in that direction, they might give it to you in every single generation. And of course, you also have the very buzzy acquired version. Resources like to talk about some super specific cases like, oh, it's corneal transplant, it's organ transplant, he ate a lot of beef or something. But just know that the acquired version of CJD, which is also known as variant CJD, is actually very, very rare. So it actually doesn't turn up in questions that often either. And just like with me giving you the spongiform histology, that probably makes it way too easy. So I would go back to what I was saying earlier, which is that I would focus more on the fact that there's these diffuse neurological signs, and especially this myoclonus, which sometimes if they're nice, they'll give it to you in what's called startle myoclonus. The name being self-explanatory. It's when you scare the patient or you surprise them and they suddenly have a myoclonic jerk. Some other things they can give you, EEG, they might tell you a spike/sharp wave pattern, which is pretty unique amongst these kind of dementia disorders. CSF can show 14-3-3 protein, and MRI can show hyperintensity at the head of the caudate or putamen, which they can also write as just basal ganglia. And this would be on T2 or FLAIR imaging. So yeah, I would try to think of it as they tend to give it to you in some kind of combination of myoclonus plus one of these imaging studies. If they're nice, they'll give you more. And obviously, if they're really, really nice, they will tell you stuff like corneal transplant or spongiform histology. But like I said, don't ever rely on that to diagnose CJD. And like I said, CJD tends to have a very, very rapid onset, which also differentiates it from all these other dementia disorders, a lot of which I put in these wrong answer choices, so let's take a look. Choice A, mutation in gene related to presenilin-1. This is familial early onset Alzheimer's disease. And obviously that's kind of your default with dementia a lot of time where you have memory loss. I suggested memory loss in this question as well, but you got to get used to the fact that they like giving memory loss in all kinds of different dementia questions just to confuse you. But compared to this question, Alzheimer's would have a much slower progression, like I said, and no myoclonus, and there's typically nothing especially notable on EEG. Alzheimer's EEG might have things like a slower brainwave or just less complexity. They usually don't give you that kind of stuff because it's not very specific. Obviously, a really buzzy thing with Alzheimer's is stuff like neurofibrillary tangles and that sort of thing. Choice B, blockage of arachnoid granulations. This is talking about normal pressure hydrocephalus, which a lot of times in resources you'll read about the triad of gait disturbance, dementia, and urinary incontinence, also known as wet, wobbly, and wacky. You do want to know the flow of CSF, and you need to know that normal pressure hydrocephalus is sometimes given to you in answer choices in this way, where they talk about blockage of arachnoid granulations, or it could be like fibrosis or something weird like that. And again, like a lot of these other conditions, it doesn't have myoclonus like CJD has. Choice D, aggregation of tau proteins. This can actually refer to both Alzheimer's and Pick's disease, even though different resources will tell you different things. A lot of people like to associate it one or the other way, but tau proteins actually appear in both. So in Alzheimer's, the neurofibrillary tangles is made up of tau proteins a lot of the time, whereas in Pick's disease, frontotemporal dementia, that's what forms the Pick's bodies, which on histology just look like these really big black circles, basically. Choice E, buildup of Lewy bodies in the brain. This is obviously Lewy body dementia. We often think of it in association with hallucinations and Parkinsonism. Sometimes they like to bring up alpha-synuclein. That's what Lewy bodies are made up of. Finally, we have choice F here, decreased function of ceruloplasmin. This is referring to Wilson's disease. So Wilson's disease is autosomal recessive, usually due to inability to secrete copper via the bile. And that also results from the mutation ending up causing it so that they cannot transfer copper onto ceruloplasmin, which is usually what carries copper around in the blood. Obviously, there's a lot of really buzzy things they like giving with it. You can have hepatic failure. You can have Parkinsonism, especially in a younger patient. If you see Parkinsonism, you should be immediately suspicious of Wilson's disease. Obviously, the most buzzy thing is the Kaiser-Fleischer rings, where you do the slit lamp exam and look into the patient's eye, and around the iris there will be a layer of copper. Obviously, don't overly rely on the Kaiser-Fleischer ring. That's way too buzzy, way too easy. So yeah, bring it back. Obviously, these dementia disorders, differential can be kind of difficult if you're not super familiar with them. You just gotta drill them, but for CJD in particular, always notice the myoclonus, the rapid onset, and just know some of these other buzzy findings on imaging studies like the spike wave pattern on EEG, 1433 protein on CSF possibly, and the MRI that shows hyperintensity at the basal ganglia / caudate and putamen. I hope you found this video helpful. I'll see you in the next one.